So, good evening, everyone. I would love to, first of all, say welcome to our live webinar educational session today about COVID-19 pandemic. And allow me to, on behalf of Ministry of Health and Prevention, United Arab Emirates, from Al Qasimi Hospital, Sharjah, to welcome our guest of honor. First of all, I would say Dr. John Fajadeh, the co-director of International Cardiology Unit, Clinique Pasteur Toulouse. And on the other side, Professor Khafer Iskan from Clinique International, or Head of International Interventional Cardiology Section, Hospital Clinique San Carlos, Madrid. Welcome, Khafer. Myself, I'm Dr. Arfan Nouriani, Head of Cardiac Center in Al Qasimi Hospital, Sharjah, United Arab Emirates. And with this, I would like to our colleagues and friends joining us this session, and hope that it will be a very interactive session later on, where John will be of great help and support to moderate this session. Well, I would like to say COVID-19 pandemic really became a great challenge and impact on our healthcare systems global-wide. So a part of that, what we know about this pandemic is really so little, and we lack of something like randomized trials or evidence-based medicine in this and management of our interventional cardiology problems and management, especially in the era of acute coronary syndrome and stable angina. So a lot of things, challenges are faced by our colleagues in the Cath labs, and that's going to be our aim of this webinar today, to through some kind of glimpse in what is the daily practice in our area compared to the areas in other parts of the world, like Europe and US or Far East. Certainly, this challenge has been bringing with it a lot of dynamic changes. So we cannot just stop and write a protocol or a guideline or whatever to implement. We have to be quite dynamic and flexible and change day by day as the virus spreads faster and faster across the globe. So let us see how much we could aid to this disease and fighting this disease. And with the help of your questions, certainly we'll be more than happy to share with you our experience in our part of the world. With this, I would like to hand over to John to moderate further the session. John, please.
Okay, good evening, everybody. Good evening, Haref, and good evening, Javier. And again, thank you for all of you joining this webinar. So this webinar will be divided in two parts. The first part, we will talking about the impact of the COVID-19 disease on the organization on the hospital, organization of the Cath lab, organization of the team, and the impact that of this disease have on our way to work in daily practice. And in the second part, we will focus on the specific disease, and particularly how to manage the patient with acute coronary syndrome, STEMI patients, and also how to manage stable patients. So the first part we will discuss with Javier, and Javier Scanet is the head of Interventional Cardiology Department in San Carlos Hospital in Madrid in Spain. And he had this particularities to be all this area, Spain, and particularly the Madrid area, was really hit by this disease. And of course, it's certainly the best person to talk about, the impact of this disease on the daily practice in the cardiology department, in the hospital, the cardiology department, and particularly in the Cath lab, and how to adapt this with our team. He has a large experience, and my first question will be, how do you think that this COVID-19 disease may influence the practice of interventional cardiology, and particularly the way to prioritize the patient, the way to organize all the team and the setup in your hospital?
Thank you very much, Jan. Thank you very much, Dr. Nouriani. Well, of course, it's a pleasure to be sharing with all the colleagues in the region the experience that we have. And what I'm going to actually share with you is, in part, what we learned also from colleagues that were facing the same problem before, the Chinese colleagues first, the Italian, and it was, I think that we were in a way the third in a row. And as you were mentioning, we were very badly hit by the epidemic. I think that, I have prepared just this slide to send the key message. And the key message is that the narrative of what happens everywhere, first in China, then in Italy, then in Spain, now in the UK and the USA, is always the same. And you have here you can see here some tweeters from Ajay Kirtan in New York a few weeks ago, where he was basically saying, we are completely overwhelmed. We are completely overwhelmed. The key message, therefore, is you have to prepare your interventional cardiology unit before the surge of COVID-19 patients come. This is the key aspect, because when it comes, it's too late. Suddenly the whole hospital will be following a type of command and control form of management, where you will have to follow, decisions that are made for the good of the majority of patients. You will have big restructuration of your hospital, and it may be too late to implement some of the things that are important. And following what Jan was saying, I think that these are basically the aspects that we could discuss, and I will bring it back to you, Jan. I think that first is the aspect of organizing the tasks of the personnel is really, really important, and then also how to protect your team and your patients from infections.
Okay, so it's interesting to have, of course, your opinion on these different points, and particularly how to, prepare your Cath lab and to give the different tasks to your personnel. How do you manage that?
Yeah, so basically, the first thing, let me just go back to this. I think that I'm sharing my screen with you. I should, let me see, sorry about that. So sorry. The first problem that you may face, certainly it was our problem, are the consequences of the lockdown that typically happens during the COVID-19 pandemic. The social isolation, lockdown of schools, for example, or closure of schools, that brings the problem of of the childcare by colleagues that have children and have no one that can stay at home with them, problems with transportation. Second thing is that you have to identify immediately those colleagues in the team that are at a particular risk. And you know that obviously age more than 60 is a risk factor if you are infected with COVID-19. So, and also patients that have concomitant medical conditions, like for example asthma or any other disease that will favor a poor evolution of the infection. What you should do is identify these colleagues and assign them to tasks with low risk of infection. I will mention in a second some of the ways that you can do this, for example, by doing telework. Second thing is that you have to remember, it happens everywhere, that there will be staff shortages. I'll give you an example. In our unit, we have 17 nurses, and now currently, during the COVID-19, at this stage, we only have 5 nurses. 5 operative nurses, because some of them got infected with the virus. Some of them are on quarantine because they were in contact with someone who got infected. And some of them were requested from the coronary care unit, from the intensive care unit, because they needed nurses under the shortage of personnel that they had over there. So you have to anticipate this. In terms of the colleagues, for example, what we do, because you will also notice typically a decrease in the number of cases. I think that Dr. Nouriani will speak about this later. But you can organize the team in small sub-teams, so to speak. So typically what we have now is only 2 interventional cardiologists working in the morning, 2 interventional cardiologists on call overnight, so they can call for primary PCI, etc. And then all the other colleagues are doing telework from home. So we avoid at the maximum the possibility of having these chances of infection. And as you can see, we also organize typically video conferences to exchange information and to keep morale. Now, it's something if teleworking is a very good way of keeping your colleagues, working at a distance from patients. In some cases, what we have to do is to request the hospital to have VPN access from remote laptops so they can access to the hospital data of patients, and they can do this work from home. And of course, they will be contacting, outpatient clinics were completely closed down. So the patients were contacted by phone and having, as I say, access to the data. And they were extremely happy, patients, not to come to hospitals, to the hospital at the time that they are really scared about the possibility of getting infected.
So thank you, Javier. We well understand the impact of the disease in the organization of the hospital, the organization of the patient flow. But my question will be now concerning your activity, your personal activity for you operators, interventional cardiologists, and all your team, how the current situation has affected your practice.
Well, I mean, obviously, as I say, the first thing we have to do is to make sure that we were operating in a different way. And here we come to speak about safety. And, when we speak about safety, we have to remember now that the main problem we have is that we are dealing with a disease that is highly contagious. And that we will have to bring patients to hospital on some occasions, not being completely sure if the patient is COVID-19 or not. Now, again, if I want to share an important message, something that is, frequently overlooked, is the fact that personal protection equipment, which is something, that deserves some time to discuss, because you need to learn how to get it in and to dress and how to undress, etc., is actually just a very small part of the mechanisms of infection control that you should implement in your cath lab. I mean, obviously, the first level, the most efficient one, will be elimination of the hazard. So later, when we speak about why, for example, a position of performing thrombolysis and avoiding that patients with COVID-19 come to the cath lab, is actually the most efficient way in some circumstances to actually protect your team, for example. But you can also substitute the task. For example, if you have to perform a pericardiocentesis, instead of doing it in the cath lab, you can do it at the bedside. You can also have a number of engineering controls that we are going to talk in a second, like, having a specific cath lab with a number of engineering, so to speak, measures to improve infection control. You should change the way that people work. You should emphasize, remember that in a way, the interventional cardiology is a culture that does not have a culture of working in high-risk biological environments. Many interventional cardiologists in Europe, for example, work without a face mask or even a cap. I think that this is going to change from now onwards. But I think that you have to really generate a bit of awareness in the team that a number of measures have to be informed. You have to change the people work, and then is how later come PPE. So Jan, coming now about specific to some aspects that have to do with this higher level of infection control than restriction PPE. The first one is to have a dedicated COVID-19 cath lab. That could be the idea. If you have two cath labs, try to convert one of them in a cath lab that you will be dedicating for this. And you know, you will bring only COVID-19 patients or those that you think may be infected. You make sure that the negative pressure is working, or at least that positive cath lab pressure is not turned on, because otherwise you will spread the droplets, you know, out of the cath lab. You should, again, and this is the way that you should change the way of operating. Once that the patient goes in, the communication door gets shut, and you avoid that there is a nurse going in and out of the cath lab. In the cath lab remain only the operators and a nurse who is going to be helping the US operators. You are sure that you have good communication from outside, and of course that everyone knows how to use the PPE. And something that is also that we learned that is important. You can do it in different things. You can either have a stock of material inside the cath lab that is never going to get out of that particular cath lab, or the other alternative is remove all the balloons and catheters you have, leave them outside, okay? Because remember that once that they get contaminated with the first patients, you will not be able to use that in any other cath lab. It will stay contaminated for a number of days. So it's much better, and that's what we do in our case, is we keep in stock, we took out all the balloons, etc. We leave them in the control room, and they are handed over to the people that are doing the PCI at the most convenient time. That's the only time that the door gets open for a while, and you know, and the nurse is handing the balloon or the wire inside. And the other thing is that you should, you know, try to do the cleaning after 1 hour after the procedure, because you have to wait until all the droplets calm down. What we do in our case, also we learned, is never go out with your lead apron, because otherwise it can be contaminated. It is better actually that you leave the lead aprons inside, and that you make sure that you get out and dress from your PPI inside the cath lab. This is something that actually is very important. And I think that something that, you know, will be important in getting ready is that understanding how to dress properly outside the cath lab, and understanding how to undress properly inside the cath lab before going out. This is extremely important to avoid, to decrease the risk of infection.
Excellent. Any question, Aref, to Javier on this particular, you know, really precise point, how to prepare the cath lab in order to minimize the risk of dissemination of the infection?
Well, I agree with all what he said. I mean, that is really almost perfect situation, what Javier is explaining there. And we try to establish almost the same setup in our facility, because as he emphasizes, there are a lot of small things that may be missed and cause some kind of contamination, especially the part of the aprons and the hardwares and all that kind. We have to clean, we have to take care of, we have to take care of our co-workers, and the limited manpower that we have, in particular our area here in our facility, we have to be even double careful, because once you have people under quarantine or something, then you are really in trouble. You have maybe it's easy to shut down the cath lab. We should bear that in mind. So I think that was really very impressive. Thank you.
Thank you.
So Javier, now you have the working in the cath lab, and just a question, the patient identified as a COVID plus patient is going via in your cath lab via a special way from a part of the hospital. Did you divide your hospital, the cardiology department, in the two parts, COVID plus or non-COVID patient? How do you manage that?
Yeah, that's exactly, well,
Pre and post cath lab.
As Dr. Al-Nouriani will be discussing, you know, the type of cases that we do these days are largely acute coronary syndromes, and then some selected cases where, you know, that have a stable or crescendo angina or unstable angina, where we identify that they should have PCI. Now, STEMI patients, they may come from outside, you know, in our case, because we keep in Europe, in Spain, we keep ongoing the program of primary PCI. And therefore, what is very important is that you always are careful. I mean, every patient comes in the cath lab, of course, wearing a mask. Okay, that's the important thing. The patient is interrogated before in the ambulance if he had already fever, if he had any, in case that he is not a known patient with COVID-19. And in case that he was in contact with someone with the infection, with the virus, in case that he had some symptoms that may be indicating, you know, that he may be actually developing the disease, this patient is, of course, is moved directly to the COVID-19 cath lab. This is what we do. Of course, you have the second type of patients that come from the COVID area. Patient, you know, who is in hospital with pneumonia and is actually, as you know, many of these patients have cardiovascular complications, and he may be brought to the cath lab for that reason. Of course, this patient will go immediately to this. From a more general perspective, Jan, I mean, when patients come to the hospital these days, you are completely right. They are cleared if they are COVID-19 patients or not, or whether they have you know, symptoms provided that they're COVID-19, and they are moved to different parts of the hospital. That's exactly what you were saying. But the message is, first, always be on guard. Remember that, you know, on these days, you should be very careful because any patient may be in a subclinical stage of the COVID-19 epidemic. So you should be very careful overall in all patients. But for those that you have high likelihood or confirmed COVID-19 infection, if possible, if you have 2 cath labs, use one of them for these patients.
Thank you. It's very clear. I have just a last question for you. When you talk about all these measures that you have taken for, you know, in your department, particularly in the cath lab, with your colleagues and all the people working with you in the cath lab, did you organize some special training session for the nurses or the doctors?
Yes, it is exactly. It's very important. I think that you can find in if you go to the, for example, the research hub that in PCR Online we have dedicated for the how to treat patients, how to address, you know, the COVID-19 pandemic. You will find videos where you find how to dress and undress the PPE. Now, it's extremely important that you do all the dressing and undressing with someone supervising you. Really important, because it's very easy that you forget something. It's very easy that you remove the first part of gloves and then you instinctively go and try to, you know, grab your glasses or grab your cap or your mask. It's very important that someone does this. What we do is we have a stick on the wall. We have a scheme, written scheme of every step that you have to follow. And whenever possible, one of the nurses, you know, will be just checking that you are following every single step. Particularly getting undressed. It's very easy to contaminate something when you are getting rid of the PPE. This is very easy. So, you know, the best thing is that you double check that you have another person who is helping you.
Okay, thank you. Thank you very much, Javier. I think it was very clear and really useful for the people connected, and even really for myself, because we are talking very often about this disease and the way to protect, you know, all the staff, all the around you, we're working with you. And now I think we can move to the, did you have anything to add, Javier, before moving to the second part of this webinar? We will talk about the STEMI patient.
I'm sure that the colleagues, you know, will be posting questions later.
Yes.
So from any time we can come to these topics. Yes.
Yeah, if we have some question now, or we could have the question at the end. Is there any question coming from the audience, the people connected?
I see that there's one that Ghazal Ziad is asking, can you please review the ventilation requirement if you do not have a negative pressure ventilation in your car lab?
Yeah.
or do you use a HEP filter? Yeah, I mean, and this is a very interesting point. If the patient for whatever reason is on CPAP, for example, you should use a HEP filter, you know, to make sure that the air that is exhaled by the patient is not sending particles.
There is a question coming from Dr. Gazaltia that can you please review the ventilation requirement if you do not have a negative pressure ventilation in your cath lab? Do you use an HEPA filter? Yeah,
this is the question I was addressing.
Yes.
And then the aspect is, you know, negative pressure is typically you do not have it in cath labs. Most cath labs have positive pressure, because most cath labs, what they are trying to do is to make sure that germs do not get into the cath lab. Okay, so typically you have this in hybrid rooms. In that situation, you make sure that you turn it off in case that you have positive pressure. If you have negative pressure, then can be a way of playing it even safer. But that is not available in most of the places.
And the question on the, you know, the question on the quality of the mask that you wear in the cath lab. Do we need a special N95 mask, or a surgical mask is sufficient?
So of course, I mean, it's, you know, the patient, when the patient comes into the cath lab, the main risk that you have is that you have aerosols or droplets that go into the air. Of course, I mean, that is, you have higher risk if the patient is on CPAP. So ideally, the patient should not be on CPAP, or if you have to do any type of instrumentation of the patient, like intubation, that of course always should be attempted before the patient comes to the cath lab. That's really, really important. Now, regarding the masks, typically what we use is an FFP2 or 3. If you are using one of these FFP2 that have a valve, remember that this will allow you to sense germs outside, so you will be at the risk of contaminating outside. In that case, what you should do is to wear a conventional surgical mask on the top of your FFP2. Otherwise, you know, if you have an FFP2 or 3 that has no valves, that's the ideal situation, because then you are completely sealed and you have no chances of getting infected. We also use goggles, you know, sealed goggles, so there is no risk of also getting any droplets that go into your eyes. And that's basically what I would say in terms of the facial mask. And we also wear a face shield, a plastic face shield that is an extra barrier for, you know, any. But I must insist, in general, we interventional cardiologists are pretty much protected from the patient, because, you know, we have also typically the lead shield that we use also to protect. And if the patient comes with wearing a face mask already and you are properly protected, I will say that the risk of contamination is much lower than if you're working directly with patients in a very close distance in the ward.
Okay, thank you. There is a lot of questions, but I think we could come back to the question after the second part. During the second part now, we will discuss with Professor Aref Al-Nouriani on the specific problem of acute patient, particularly STEMI patients. But we could discuss also the opposite, how to manage the stable patient. In Europe, for example, in France also, we see very clear and strict, you know, recommendation for the National Health Administration and from the different hospitals to really focus on the critical patient, acute patient, and try to delay all the non-urgent intervention, could be or medical patient, interventional procedure, or surgical intervention. So, Aref, what is the situation in the Emirates today?
Well, John, thank you very much. Maybe I can start with this slide here, just to show that we have been also involved in this COVID-19 pandemic. And the curve shows very clear that we are currently reaching almost the peak week here. And that is really alarming here, everyone. Luckily, we had some time to prepare ourselves. The government took all the steps earlier once the epidemic or pandemic started in China. So we had some time to prepare ourselves on the right time. And that's why we see that the numbers also in the Middle East and the Gulf in particular and UAE also not rising so dramatically. I mean, the number we have now is less than 4,000 with only mortality of 20 patients. So that's really not a big drama here. But still, we are getting now more and more sick patients coming this last 2 weeks. And we have a lot of measures taken or undertaken by the government, whether it is from quarantine and isolation centers. We have dedicated centers outside the hospitals for this, and we have field hospitals. We have a lot of things. Now let's go back in our hospital, in our facility. If we go back to our facility, we started as well to prepare ourselves, starting from the triaging the patients outside, even from the ambulance. We can get, what happened, luckily, we could, first of all, the Ministry of Health and Prevention decided to separate hospitals to COVID and non-COVID hospitals to provide some normal and regular services, health services. Otherwise, things will be paralyzed, you know. So I don't know how it is the situation in your side, in France or Spain, but we luckily became considered here in Al-Qasmi hospital to be as a, let's say, kind of clean hospital or non-COVID hospital. And that helped, or maybe it became more challenging for us to keep this hospital away from contamination through the COVID-19 infection. So then we come from triaging. What we have decided to start triaging the patients. As I said, patients will be referred to us. As you know, John, we are a center for, I mean, we are getting more than 4 or 5 MIs a day in our Cath lab, and that's a big number. And now we are facing this kind of challenge. Luckily, not so many patients infected so far, but we don't know. We know that 25% of our patients of COVID-19 are asymptomatic, and that could mislead us or sometimes deceive us. So we should be prepared and consider every patient potentially as COVID-19 infected patient. So what we have created in our accident emergency, there are 2 paths. One path is for suspected and confirmed COVID patients, and the other one is for regular normal patients with no evidence of or signs, clinical symptoms. And that eased a lot our performance and to preserve our hospital as much as possible away from contamination with this virus. And that thing follows from the accident emergency, taking the path for the X-ray department to the Cath lab all the way. There are different paths, so we don't come across regular patient's path. So that is one thing. And then what happened in the Cath lab, certainly we did what Cath mentioned. We did a lot of training, drill sessions, and with all kind of precautions, with the collaboration of certainly with the infection control committee and our infection disease department. So that helped us a lot to establish kind of system and path to reduce, not eliminate, but reduce as much as possible this kind of involvement. Besides, we are a general hospital as well, and we have dedicated people for referral cases. For instance, we get a lot of calls from Obs and Gynae, from renal unit, and all that kind of consultations been dedicated with certain doctors. And that helped a lot to not to so mix the doctors and staff with each other. So that is another thing. From the Cath lab, yes, the same thing. We have decided to go for a HEPA filter, and because the setup doesn't allow us to go for negative pressure, and we have dedicated rooms. If we go for, we decide in advance to go for elective intubation. So if that happens, we have dedicated place with negative pressure where the anesthetist feels much comfortable to do that rather than doing it on emergency base and a shock patient in the cath lab. And for that reason, but in case of emergencies and something develops during the procedure, we have a backup from HEPA filter and certainly all the kind of PPE measures. This is in summary, John.
Okay, and so thank you for giving us the, this full picture of the situation in Emirates, particularly in Sharjah. And so now we will move in the specific treatment of STEMI patient. And there is a first question that we receive from our friends. Did you avoid primary PCI for all the patient, or is lytic therapy became the first choice? In other words, what is your message for STEMI patient? It's a primary PCI, still the recommended myocardial perfusion strategy, or do we use thrombolysis as a primary intervention, or do you reserve the primary PCI for anterior MI or complex, complicated MI, or patient with, impairment of the LV function? What about the problem for STEMI patient? What are your first answer for the potential usefulness of thrombolytic therapy?
Well, John, we have certainly concern to protect our staff from any kind of infection, because we are really keen to keep everyone safe. So we decided, and if there's, as you said, no such, we try to find really established or standardized protocol and guideline to adopt somehow, but it is so different and everywhere it's different. So we thought we have to really therefore tailor something for our local need, and we have a lot of MIs. So we decided, and we don't know actually who is the one who is positive and who's negative sometimes, but we get confirmed positive cases referred from other facilities, and that plus people who have really, as it is shown in the diagram, I don't know if you can see it, appreciate it, John, Khafer. Yeah. So, and our colleagues certainly, that we have high suspicious people coming from countries, for instance, in the last 14 days, from one of those epidemic countries, or some kind of history of contact to close person with positive COVID, plus others. So if we have those two groups of patients, they go directly to thrombolysis. So we don't exempt anyone here. So they go directly to thrombolysis. And that's how we do. And if there is no such, and there is a dedicated.
And I have a question on the comments of
and if it's not on the left side, you can see.
Concerning the thrombolysis. We have been thrombolizing patient and keeping PCI for rescue indication. Maybe Dr. Nouriani can answer when such patient can be taken to cath lab, especially in this part of the world, in your region. So this is really exactly what you explained today, the protocol that you use for to take care of the STEMI patients.
Yes,
so
sir.
We understand with Javier that thrombolysis is the first the first answer to the STEMI patient, systematically.
Yes, sir.
And then after thrombolysis, what are the different options?
Well, as you can appreciate, then after that we have either to go to the kind of unstable patients with electrical or hemodynamically, where we consider here ECMO or Pella also placement. Certainly we try to avoid as much as possible any aggressive engagement, but sometimes it's unavoidable, as you know. So if the electrical or hemodynamic instability is there, then we go to rescue PCI and to the cath lab, the hybrid cath lab. If there is no such, then we continue with medical treatment, and then we'll be referring him to the consultant of infection control disease department, and then shifting him back to the COVID center back. We don't keep them here anymore. That's one part. And that's the same thing on the other side. If you can see on the right side, if there is a little bit more generous, if there's with a highly suspected kind of COVID-19 patient with those clinical picture, then we go for including a persistent ST elevation more than 50% for over 90 minutes. Then we go to if yes, that is the situation, or hemodynamically instability or electrical arrhythmia or kind of malignant arrhythmia. Then we go for high resolution CT. If that seems to be normal, then go to rescue PCI again, if there is instability as on the left side. If not, then we continue with rescue PCI directly. That's how we approach the STEMI in our center.
Okay, so for this patient, Javier, you want to add something?
No, I just wanted to say that actually,
to comment?
Just to bring some of the comments from the colleagues, because they are piling up. We have a lot of questions, and thank you very much to the participants for being so active. And actually, there was a colleague, Prapul Mishra, who was saying, assuming patient remains stable post-thrombolysis, when would you proceed with an angiogram? That is the question to you, Arif.
Well, what we have done here,
I think we
our telemetry kind of consultation with our patients, and we are not planning to call them if they are stable or asymptomatic, remains asymptomatic. We are not planning to call them meanwhile till further. So there's no such fixed plan to come after 5 weeks or 6 weeks. We don't have that. We wait till this pandemic maybe ends.
Very good, yeah.
And there is an interesting question coming from one of our colleagues. If the way to perform PCI, in other words, if you need to perform PCI, to rescue PCI in an unstable patient, the question was for Javier Scanet, but this could be extended to Aref. It's concerning, you know, the modern PCI techniques of imaging, etc., calcium modification, if you have a calcified lesion. Do you use the same technique as you used before the COVID-19 infection, or do you use this high-tech technique in less cases now today with a COVID-19 patient infection?
Thank you. Yes, so specifically for the topic of STEMI, which is now being addressed by Dr. Nouriani, what we do in patients with STEMI and multivessel disease is now, during this COVID-19 pandemic, is to stick to recanalization of the culprit artery. And then, you know, leave for a second, for a later stage procedure treatment of the non-culprit arteries, because we believe that at this point, you know, remember that until the complete study, all the other studies have demonstrated that the main benefit was a reduction in revascularization rates. The complete study has demonstrated that actually, when you have big figures, you can also see a reduction in the mortality rates. But it is true that, you know, if you see that the non-culprit artery is, say, not a proximal LAD or something that is really compromising the prognosis of the patient, we prefer to stage them for a second point. And now also applies, and I think that later Dr. Nouriani will speak about this, to patients who have multivessel disease and that are highly symptomatic. Perhaps one of the few subsets of patients, you know, with unstable or crescendo angina that we nowadays do. We only do those, said to speak, out of acute coronary syndromes, patients where we think that performing an intervention may have an impact on the next 3 months survival of the patient. Well, in these patients with triple vessel disease, for example, we follow a similar approach. We prefer to focus in the stenosis that accounts for most of the ischemia at this particular point. And then to a stage for later a treatment of the non-culprits, because in that case, as the colleague was suggesting, you will have more time, you will be in a much more relaxed situation to perform this with, plaque modification techniques, etc. Jan, I think it's very important that we remember the colleagues that the problem that we have in performing PCI at this point is that many units and many services in the hospital that typically are operative and contribute to the safety of complex PCI, for example, the possibility of asking for an urgent CT scan, for example, the possibility of sending the patient, to the ITU because you have to really manage a complication or whatever. These ancillary services are not available in many cases during the COVID-19 pandemic, where the hospital is dominated, by admissions with COVID patients. So for that reason, we really have to simplify our procedures now. We have to really always balance the risk that the intervention may have, or the risk that we may have of needing one of these extra resources that at this time may be compromised.
So I read, thank you, Javier. I read there is some question coming from our colleagues, and particularly in the environment of STEMI patients. One of them is the use of dual antiplatelet therapy associated with heparin in STEMI patient. And the question is concerning the safety of this association. In other words, when you are doing thrombolizing the patient, do you use the same anticoagulation treatment associated with thrombolysis that we use in a non-COVID patient?
Yes, sir. We do the same protocol. We don't take. We take the dual antiplatelet therapy according to what we usually practice in the dual antiplatelet. So there's no change in that one.
Okay. Second, there was a question, but I don't know, personally, I have no answer concerning the risk of stent thrombosis in these particular patients.
Well, let me say one thing, John. Is it a question to me, right?
It's a question to, yeah, addressing for the, and a question for you and for Javier.
So we've seen already cases of stent thrombosis, and actually yesterday we were talking about, with colleagues in ITER, etc., to perform a registry on this particular topic. It might be interesting also, in the Middle East region to do a study about that. I mean, we certainly have seen cases I could share with you. And it makes a lot of sense, but simply we don't have the evidence that because you have huge inflammation in these patients, and inflammation, of course, is triggers, modifies the thrombotic profile and favors thrombosis in these patients, that you may have more stent thrombosis. But the fact is that we do not have figures. But I only can say from our experience that we had cases of stent thrombosis in situations actually where the patient was in the COVID ward doing very poorly, and suddenly comes with the myocardial infarction, and you can see that it was the stent thrombosis in a stent implanted, 5 years ago or something like that. So it is a possibility. And I think that later, there are many colleagues that are asking about the problem of coagulopathies and microthrombosis. We will speak about that later.
Any comment, Aref, on this problem of risk of coagulopathy?
Well, we know that majority of the complication related to the procoagulopathic milieu of the disease, and that is a big challenge actually. I don't know, we don't know much about the disease, John. Still, we are really trying to dig in darkness how to manage, and luckily we didn't see many of those cases yet, as you have seen maybe in France or Spain. We have really limited experience with this kind of stent thrombosis. But I would say maybe if we are so worried, maybe to reduce the kind of at least technically related malposition or something to optimize maybe the stent placement to reduce that kind of thrombosis. That is something I would recommend in that era. That's all what I can say.
Yeah, I think what we know so far is that, in about it's difficult to say the percentage. I will say that probably between 10 and 20% of acutely ill patients with COVID-19, you may have ST elevation without actually finding an acute occlusion of the vessel at the time that the patient comes from primary PCI. And you know, as you know from pathology studies, what we are learning is that in a way, these patients behave very much like patients having an antiphospholipid syndrome. They have extreme formation of microthrombi that typically happens in patients who have high D-dimer, high elevated markers of inflammation, interleukin-6, and perhaps also in those patients who have very high levels of ferritin, early levels of ferritin, serum ferritin. So we are learning about this. It is a fact that is one of the mechanisms by which the COVID-19 infection leads to ischemia. And as I say, unfortunately, in many occasions, at very late stages of the disease.
There is a question for you, Aref, coming from one of our colleagues, telling that assuming patient remains stable post-thrombolysis, when would you proceed with angiography?
Again, as I said earlier, we wouldn't go. If he's stable, we'll contact him. We'll keep on following him so far, and there's no such plan for angiodiagnostic elective angiography meanwhile. We have really to preserve our staff as much as possible. We are very much keen to keep them safe, and we are really I discussed this with Khafir maybe recently, that the number of interventional cardiologists in the country here are not as many as you have it in Europe. So we should be really careful and reduce as much as possible the exposure of our staff to the patients.
So your strategy of management of the STEMI patient make some questions on the role of primary PCI, and we have at least two of our colleagues telling that maybe primary PCI should be maintained in the UAA. One of the colleagues asked for asking for a unified strategy of primary PCI in the UAA. What is your answer?
Well, John, as I said, this depends a lot on what is going on in every region and every facility. We have some kind of different, let's say, organizations in the country. We have a little bit unique kind of structure, and every organization would supposed to find and tailor for himself the way he thinks it's suitable for his patients. Now, certainly we have under the umbrella of Emirates Cardiac Society kind of consensus, and we will be discussing this, but this is really running dramatically and we are running out of time. I mean, the moment, as I said, we think of something turns up and something goes in the other direction. It's a lot of dynamic changes happening around us, and with a lot of challenges. So yeah, I think I agree that we should have a unanimous kind of protocol or management strategy, but let's try with what we have now.
Okay, thank you. There is also some question concerning the technical question concerning is there a preference for the access site when you are performing PCI in a COVID patient? Is it better to use radial or femoral, or it doesn't matter?
Well, we are doing something like 98% of our cases performing them radial. I mean, you know that with us. And only if we fail with radial or some complication, we go to femoral. And I think it's safer to do it radial in this particular setup.
Yes, we fully agree as well, because first is that if you are thinking about the distance, actually you are more distant from the face of the patient if you are using radial, if that's your concern, which I think that typically with all the LED screen, etc., is not that much of a problem. But most important is that these patients, you know, you need to change in many occasions of position. So, and also the possibilities of having a complication, if you have a femoral complication, which is rare, but if you have it, you know, again, you may need more resources like a CT scan or whatever, which at this point may be a problem, particularly during the search of patients. I'm talking from my perspective. In a hospital, you know that suddenly is completely overwhelmed, and when it is really a big problem to ask for a CT.
There are two other questions concerning the STEMI patient. One coming from Abuantash asking that, and this for you, Javier, what's percentage of Minoka STEMI patient at your center, like a fulminant myocarditis, and any advice to minimize chances of taking them to Cath lab and give them lytic therapy?
Well, first is that if you are judging Minoka because you are seeing a raise in troponins, you have, as you're rightly saying, that in many occasions this can be a manifestation of cardiovascular involvement, but should not rush you to take the patient to the Cath lab. I mean, on the contrary, should perhaps make you focus on what can you do for the patient in terms of the underlying condition. If you have someone who has, of course, huge deterioration of the left ventricular function, if you see a case of myocarditis, I think that we've seen only one case like this, you know, you really have to proceed. We still don't know if in this situation of myocarditis, COVID-19 myocarditis or suspected COVID-19 myocarditis, it is of any help considering biopsy, for example, to understand if you have the virus there or something. At this point, we don't know if this will help. But in general, for any patient that, you know, you have a suspicion that something is going on because you have seen repolarization changes, not ST elevation, repolarization changes with a mild troponin rise or whatever, my suggestion will be in a COVID-19 patient, do not rush to bring the patient to the Cath lab, because this can be a manifestation of the organ. Try to focus much more with your colleagues from internal medicine, from infectious diseases, etc., in understanding if the patient is having a lot of systemic inflammation, and try to address that, either, you know, with anti-interleukin-6 drugs or corticoids or whatever measure that you think that is indicated in a patient that is at a very high level of systemic inflammation.
Ares, there is a question concerning your algorithm that you showed concerning the STEMI. Particularly, we have to come back on the first line. In other words, on the left, you have the COVID-19 negative or not suspected, then the positive, and there is a case of suspected cases when, you know, the diagnostic, it's uncertain. And the question is, why to test and to wait for the test for COVID? And if you test this patient, the question is, this maybe will cause a delay in the treatment.
No, we are not waiting for the test results. This is only for the prognosis and the further follow-up and
okay,
what is the plan for the patient in the future. It's not for us because that takes 6 hours. The test takes 5 to 6 hours, and nowadays it takes even longer than that. So we don't wait for the results. But every MI or every STEMI patient comes, whether positive or suspected or negative or non-suspected, we do something for the procedure.
Okay, it's very clear. So all the MI, COVID or suspected for COVID are treated by thrombolysis, and then you will wait later. We look later at the result of the test. Okay. Another question concerning the use of ECMO in a really unstable patient with severe pneumonia or cardiogenic shock. Do you see an indication for that?
Answer more, maybe he has seen. We have it, but we didn't have to use it in any case so far.
Javier, no, experience with ECMO?
No, we don't. We didn't. I mean, obviously, there have been other hospitals that have been using, that I'm aware of, that have been using ECMO as a way of addressing the pulmonary problem of COVID-19. But fortunately, in our case, we were not in a situation where we have to go for ECMO, which of course poses, a number of difficulties. Among them, again, the limited resources available at the time of the COVID-19 surge.
John?
Yes.
I know from our colleagues in Dubai and other part of Emirates, they've used ECMO on a lot of those COVID-19 patients and with great results. So really helps a lot. So just for the comment.
Okay. So we talk about RF STEMI patients, and what about the more stable patient?
Well,
have you any recommendation for the treatment for stable patients, and when to perform angiography?
Well, optimize medical therapy. That's what we say. Defer everything for later on. As long as patient is stable, we keep on regular calling them, chatting with them, seeing if they have developed any symptoms or any symptoms at any time. We call them back to come in.
Okay. Other comment, Javier?
Sorry, I could not hear properly the question.
That was the problem, the issue of a stable patient. Is there a different type of management of this patient that we have done previously before the COVID infection, or have you the same recommendation for this kind of patients?
Yeah. So typically, we divided the patients according, to the different type of risk. And in a nutshell, the only patients that we are doing now with, chronic coronary syndromes or unstable angina, progressive angina, or, someone who has undergone an exercise test and is highly positive, whatever, in these situations, we only go for cardiac catheterization and revascularization whenever we anticipate that not performing some sort of revascularization will have implications over the next 3 months. So that's the reason, because I say, and again, we try to do in that case, in case that we find multivessel disease in these patients that clinically, you have a reason to investigate and to move forward. We try to perform some sort of reasonable revascularization. We aim for the most the stenosis that accounts for most of the ischemia or the clinical presentation, and we defer the patient. So hopefully we will be able to bring this patient back after 1 month or 2 months and complete the revascularization of the patient. This time, using all type of armamentarium, physiology, imaging, plaque modification that we typically apply to these patients.
Thank you. And there is a question on the frequency of and the number, the percentage of patients with STEMI. In other words, in Europe, we have we saw that the number of STEMI patients was dramatically reduced in all the countries. Same for stroke patients. This is certainly due to the confinement of the population. Did you see the same picture in the Emirates?
Well, yes, John. I didn't know how to explain it, but we had a reduction maybe by 30% of our STEMI patients coming to the Cath lab. To the extent we were wondering where are the STEMI patients that just disappeared to. So that is something I don't know. Maybe you can help me in understanding what. But we believe that the population structure in UAE, we have something like 80 or 85% of expats in the country, and they are all labor worker, most of them, and they work really hard. And that could be this kind of stressful work sometimes can lead to more kind of stressful situations and prone to develop more STEMI. But That's the only thing that we could say. Now they are more relaxing. I don't know. Something.
We have, we actually, you know, the first in describing this phenomenon were the Chinese colleagues. There's a paper, a published reporting this typical pattern of disappearance of patients with STEMI and then reappearing, you know, later. And it also happened in Italy. It certainly has happened in Spain. And also what we are seeing in Italy and Spain is an increase in the number of patients who arrive very late. I mean, they really arrive when they have already completed, you know, the infarction. We've seen more cardiac ruptures than we see in years, you know, in this period. So recently we had an operation in a patient, you know, who in a way was feeling some chest discomfort, but the patient, of course, was very reluctant to come to the hospital because of the COVID-19, the risk of infection, blah, blah. So our impression is that many patients are scared, and you know, and they are not paying attention. They're not calling 112, saying that they have chest pain like it was before. It may also happen that sometimes they are overlooked, you know, that they call emergency services and they don't make a clear statement of what happens, and the emergency services can be perhaps overwhelmed. We don't know, but it is a reality that this thing happens, and that it is also a reality that it pays off in terms of having more late arrivals. That's a pity.
Thank you, Javier. There is two more questions on the potential role of robotic PCR using the correndus in order to reduce, you know, the patient contact. Have you an opinion, Aref, on that?
Well, you know, in the era of STEMI, maybe I wouldn't recommend at this stage. I would really prefer not to go with robotic for STEMI with the COVID-19 patients. I don't know. It's maybe John, you have also now experience by time with this robotic, so you can also add something. But I think quick in, quick out, and minimize the exposure. No more extra setups, no more extra machines, no more, you know. Soon, a quick in and quick out.
Yeah, because I fully agree with you, Aref. Even using the robotic, the robot correndus, you have to, you know, you have a contact. There's still a contact with the patient, particularly when you are doing the catheterization, when you connect the robot to the guiding catheter, when you exchange a wire, etc. So we have the gloves on the table as without correndus. Another question is concerning the use of kissing balloon. This is a technical question. What I will say is COVID positive COVID or not, our role is to treat the patient correctly, quickly, but with a safe and stable long-term result. So we will do exactly the same.
I think so. There's one colleague, John, that is asking,
yes.
Asking me about how many of our colleagues were infected with COVID-19. I must say that we were very lucky in terms of the interventional cardiologist. None of my 9 colleagues have been infected. So, I can tell you that in the cardiology service, we had, on the contrary, we had 4 colleagues who had the disease, but actually, and luckily, they evolved very favorably. And some of them are actually back after having negative tests 2-3 weeks after the. So I think that this is more a risk. This emphasizes that if you are careful, the interventional cardiologist is not the physician who has the highest risk of contamination. An echocardiographer, you know, for example, is at a much closer distance from the patient than an interventional cardiologist. You have to pay exactly a lot of attention, but or the patient, you know, the colleagues who are working in the wards looking after clinical patients. You have to be careful, but if you enforce all these measures, if you play safe, the risk of infection, of course, is very small.
There is one other question I think we need to answer to this one also. It's concerning the thrombolysis. Have you any preferred thrombolytic agent or do you use the thrombolytic agent that you use after this COVID infection?
Tenecteplase I prefer more than TPA. I mean, this is whatever is available, but tenecteplase is really easy, one shot, and that's more feasible.
Yes, it's the first choice also in Spain.
Okay, so I think maybe we are out the delay of this webinar. I think it was really interesting to share with Javier, with experience in Spain, particularly in Madrid, and URF in the UAE, and particularly how to organize the Cath lab and how to prevent the safety and to take the safety measure for all the personnel working in the Cath lab, and how to treat this STEMI patient, and with your algorithm that you present. Of course, we have different, it could be different in some countries with the use of primary PCI, but we understand with Javier and all of you that when you have a COVID patient or a patient suspected for COVID, the first step is thrombolysis, and then the angiography will be indicated according to the outcome of this patient. Final word, Arif?
Thank you very much. It was our pleasure to share with your experience, and thanks for Abbott for sponsoring us in this.
We lost Arif, no?
It's really nice as well. We needed that quick in, quick out. That's key message.
Okay. So thank you, everybody. Thank you. Bye-bye, Javier.
Thank you very much.
Thank you for the participation. Thank you, Arif. And again, we thank to Abbott to be able to organize this nice discussion. Thank you very much. Take care.
Good day.